And yet it is emerging in a very big way. When we were students, and that was pretty long back, this hypophysitis was a non-descript entity. And the only time we used to rack our brains over it was as a differential of Sheehan syndrome, which, as you all know, is very common still in our country. But over the years, the picture has changed quite a lot. And in the last 10 years or so, the number of hypophysitis cases have gone up remarkably, thanks to the improvement in the diagnostic procedures, particularly histopathology, radiology, and also because new entities of hypophysitis have been added, particularly the IGG4 related disease and the hypophysitis associated with immune checkpoint inhibition. Now, what interests us clinicians is that, while hypophysitis may have a dramatic cause, it can also have a very subtle presentation. And unless we have a high index of suspicion, what can go wrong is that we will miss the diagnosis, and ultimately there would be increased morbidity and mortality due to undiagnosed adrenal insufficiency, mainly, amongst other complications. So with that brief introduction, it's now over to Dr. Praveen to enlighten us with the causes, the diagnosis, and the treatment of hypophysitis. So over to you, Dr. Praveen.
Thank you, ma'am. Thank you, Dr. Prashant, for that kind introduction. I think someone should enable screen sharing. May I request
Prashant should allow screen sharing. Prashant, allow, sir.
So while we are at that, I would like to sincerely thank Dr. Nilanjan for this invitation and opportunity. Great to interact with this Bengal Endocrine Society. I know that you are highly academic-minded guys, and I hope I can do some justice to this talk. I have sort of dedicated this talk to all those hardworking endocrine PGs who don't get to read all the things.
Like how he grows.
Yeah, so I got it. I'm going to share the slides now. I hope you're able to see my slides and hear me clearly.
Yeah.
It's okay.
It's visible.
All right. So I'm going to talk about the clinical insights about hypophysitis and about the new entities and the evolving spectrum. So as I said earlier, I hope it will be useful to all those postgraduates. So when we talk about hypophysitis, the prototype entity is lymphocytic hypophysitis. And the first description of this entity was in 1962. So this was in a pathology journal from Glasgow, where they described the case of a 22-year-old lady who expired after a surgery for appendicitis. So she had this history of Hashimoto's thyroiditis, was on thyroxine replacement, thyroid extract rather than actual thyroxine. And then she had this history of amenorrhea after her delivery around 6 months back, and was in rather ill health after that. But that was not investigated properly. And obviously, 22-year-old dying after appendicitis and surgery might have been a big thing. This prompted an autopsy, and they found that there was lymphocytic infiltration and atrophy of the anterior hypophysis, and also adrenal atrophy. So it kind of summarizes the presentation of lymphocytic hypophysitis. Peripartum, prominent adrenal insufficiency, and it may slowly evolve, and then it may mislead you. It's a diagnosis which is often missed. So in the 60 years since the first description of the entity, a lot of things have happened. If you look at the PubMed search, you'll find that more than 3,000 publications. And our information about hypophysitis has grown by leaps and bounds. We know that lymphocytic hypophysitis is just one of the hypophysitis. There are many others, and there are many secondary causes as well. There have been considerable advancements in relation to the autoimmune aspect of hypophysitis as well. So just a recap of things which all of you or most of you know about. Hypophysitis is obviously inflammation or itis of the hypophysis. So depending on the involvement, you can classify it into anterior, infundibular, and posterior or panhypophysitis. Depending on the involvement, whether it's primary just pituitary involvement or whether there is pituitary involvement is a part of a multisystemic disease, we talk about primary hypophysitis or secondary hypophysitis. So there are different entities under the heading of primary hypophysitis, which I will allude to shortly. And the secondary hypophysitis, there is a big list which I have summarized below of entities which can lead on to secondary hypophysitis. So we will look at all the aspects of hypophysitis in a structured fashion, and I'll try to include 3 to 4 case scenarios which will sort of reduce the boredom associated with the didactic lecture. So first, let's start with the presentation. I remember the first case when I was a DM student more than a decade back. So we had this 28-year-old lady, 6 months postpartum. You presented with amenorrhea and lethargy. She was diagnosed to have a low 8 AM cortisol and consequent adrenal insufficiency. She had central hypothyroidism as well. She had this classical enlarged homogeneously enhancing pituitary, and then she was just given hormone replacement, no steroid therapy was given, and I vaguely remember that there was some resolution of the mass on follow-up. So I'm not going to spend a lot of time talking about lymphocytic hypophysitis to this audience. I'll devote time to the newer developments. So we talked about the primary hypophysitis, the 4 classically described ones apart from the lymphocytic hypophysitis are the granulomatous, xanthomatous, and necrotizing. And each has their characteristic presenting features. We all know about the lymphocytic hypophysitis. It's mostly seen in fact, that's a common to all hypophysitis. The primary hypophysitis, it's more common in ladies.
আমার আসতে সময় লাগবে বাবারও এখন কেস একটা
So,
দেখছে
the
সময়
lymphocytic
লাগবে
hypophysitis is most commonly described in the 3rd decade of life in females and the 4th decade in males. And there are mimickers, there are other entities in which there is some amount of lymphocyte infiltration, which includes craniopharyngioma and germinoma. And you know the story. It's there is anterior pituitary defects, hypopituitarism, which may be partial. And initially we thought that cortisol was the first hormone to go, but that has changed now. And DI is less frequent. Usually there is a homogeneous enhancement of the pituitary, and there is usually, if you look carefully, usually the patient will have some other autoimmune disease, which may be as simple as autoimmune thyroid disease or as complex as SLE. Granulomatous hypophysitis, slightly older age group, and the DI is more, the diabetes insipidus is more common in granulomatous hypophysitis. That's the presentation is more intense. There is more of headache, more of cranial nerve palsies, and the enlarged gland and stalk thickening is always there. So there are secondary causes of granulomatous hypophysitis, starting from tuberculosis, sarcoidosis, and it can be something like a vasculitis as well. Xanthomatous hypophysitis, it's recorded in connection with ruptured Radiological, and there are some systemic autoimmune disorders are also known to be associated. This usually presents as a cystic mass, and the headache is frequently very commonly noted in this entity. Necrotizing hypophysitis is a very rare entity, only a handful of cases reported, and it mimics apoplexy. So initially we thought that there was this thing in textbook, most of the textbooks saying that adrenal insufficiency is a most common presentation, and then the others. But there are different series, and each has come up with their own findings. So we have this KEM series from India, which was published in 2013. NIH, so there is this NIH series actually compiled all the cases which were described till then, probably in 2010 or 2009. And then there is this German series published in 2015, and this Chinese series, single center series with around 50 patients. If you look, you can see that the KEM series and the NIH series, the cortisol insufficiency is the most common seen in 60 to 75% of patients. The German series, this series involved 3/4 of the patients were proven lymphocytic hypophysitis, and the others were granulomatous, and the hypogonadism is the most common abnormality here. Adrenal insufficiency is seen in around 50% of patients. Diabetes insipidus is also seen in 50%. So here in the Chinese series, central diabetes insipidus is the most common. Of course, not all patients have undergone a biopsy in this series. So it varies actually. There is some variation from what is classically described. So this is a good series of idiopathic granulomatous hypophysitis, just to get an idea about how it presents in a large series. So again, as I mentioned earlier, a lot of visual defects, cranial nerve defects is very common in this condition, and about 60% of patients have all sorts of hormone defects. The least common hormone to be involved is the growth hormone axis. So basically, we all know that the diagnosis of the hypophysitis starts from a clinical thing. So you have this patient who presents with features of adrenal insufficiency or other hormonal defect. You start evaluating. Sometimes the headache may be there. In burned out cases, headache may not be there. If the cranial nerve palsies, you come to the diagnosis faster. If there are no cranial nerve palsies, then the endocrine investigations lead you to image the pituitary, and that is where you start thinking about the diagnosis of hypophysitis. So let's look at the radiological aspects now. So a lot of things which are common to all inflammatory etiologies of involvement of hypophysitis has been described. Usually there is a triangular enlargement of the gland, which is usually symmetrical, intense enhancement. Later on, there may be an empty cella. A thickened stalk is frequently seen, and the posterior bright spot is often absent. Something which has been described, just like in meningioma, is a dural enhancement, which you can see here. Venous sinus mucosal thickening also. And this is a paracellular dark T sign. So this is seen in T2. It's not come up. This T2 aspect does not come up nicely here. You can see this emptiness just adjacent to the tumor-like mass here. This is not a very common sign, but if you find it, it's kind of pathognomonic. So this is from the KEM series. There are roughly around 25 to 27 patients. So all the classical symmetrical enlargement, hormonal contrast enhancement, etc. And the cystic changes, this is something which I want you to pay some attention to. It's not always this intense homogeneous enlargement. Of course, we had other less common entities like granulomatous and necrotic varieties also. So the cystic changes are not at all uncommon. If you look at this German series here, the necrotic center or the hypointensity in the center is seen in up to 50% of patients, and 75%. This is for the proven cases with granulomatous hypophysitis. The strong contrast enhancement is, of course, uniformly described in all series, but sometimes it's not that intense. It may be heterogeneous as well. So when I was a student, we had this debate about how to do a perfect measurement of stalk in MRI. And so this is some sort of guidance which from a large expert committee from the NHS. So you take measurements of stalk either in the coronal section where you can see the stalk starting off and entering the pituitary, or in the axial cuts here, you can see this axial cuts here. So you can take the measurement either at the level of optic chiasm or at the point of entry into the pituitary. And the dimensions, the cutoffs, all of us are aware of this. It's around 3 millimeters. This is at the level of insertion and 4 for the origin. So this is guidelines were designed for children and young people with stalk thickening. So of course it applies to adults as well. So the stalk thickening may not be the usual classical uniform thickening. There may be various variants of stalk thickening. Just upper part thickened, middle part, or the lower part thickening also is equally common. So this is a score which helps us to differentiate adenoma from hypophysitis. This is envisaged by Dr. Gutenberg. She's a lady. I think she's a neurosurgeon probably from Germany, and this has been validated with a sensitivity of 92% and specificity of 99%. So it looks at various aspects. If you have a relation to pregnancy, then the score is -4. Pituitary mass 6 cc, score of 2. Then there are other scores for gadolinium enhancement, stalk, mucosal thickening, etc., etc. And the stalk, if you have a value of more than 1, then it suggests adenoma, and low values suggest hypophysitis. That is, as you can see intuitively here. Now let's go on to diagnostic evaluation. This is where you have to make some clinical judgment, and you have to draw lines how much to investigate the patient. So basically, this is where we are at right now. We start evaluating the patient for clinical features. We have done the imaging, and the investigations, most of the investigations are aimed at trying to find a secondary etiology. So if we fail to find a secondary etiology, we come to a diagnosis of primary hypophysitis. So what are these secondary etiologies or entities? So this is a nice table, concise table, which kinds of lists most of the disorders. So there are these autoimmune disorders, APS, SLE, systemic inflammatory disorders, the common ones being sarcoidosis, vasculitis, IGG4. But this can be seen in Crohn's, Takayuki, etc., etc. This is useful to remember these things. Drug-induced, Madam has already mentioned that. infiltratory lesions, Langerhans, Erdemchester, all these we have seen in our clinical practice. Ruptured Rathkesis with surrounding inflammation. Germinoma. Kids always think of germinoma as a, when you have a suspected case of hypophysitis, and the CSF tumor markers and the serum tumor markers should be done, and even biopsy should be considered, because if you miss this diagnosis, then there is big trouble waiting. Infection, tuberculosis, syphilis is a thing of the past. Fungal infections are rare. So one of the questions which often comes up is, if you suspect tuberculosis as an etiology, what are the things which you have to do to figure out or rule out tuberculosis as a cause of granulomatous hypophysitis? Often the neurosurgeon goes in, debulks and finds this granulomatous inflammation. Often it's just a mass and we want to rule out tuberculosis. So both way, people are not very sure or about what to do, but these are some of the suggested things. Of course, Mando, all of us do that. If you have tissue, pituitary tissue, staining, very often negative, PCR in the tissue and quantiferon assay in the CSF, biopsy with cacheating granulomas. So these are the things I think all of us do uniformly. If you don't find anything in any of these things, you can sort of rule out tuberculosis. Of course, we have to look at the other sides also. So we might have to do imaging of chest and abdomen as well, looking for parenchymal lung lesions or lymph nodes as well. Investigations for secondary causes. So this has been given for central diabetes insipidus. So the same applies for hypophysitis as well. So in lymphocytic hypophysitis, very often you have all these antibodies, but this is not to suggest that all patients would have all these studies. But if you have a suggestion of a SLE or Sjogren syndrome, you should go full force and do all these antibody workup. But though it's a clinical decision, granulomatous disorders, the suspicion, what you do is you have to do imaging elsewhere, chest X-ray, abdominal imaging, quantiferon, ACE levels, ANCA leads us to granulomatous polyangiitis, or what was referred as Wegener's. CSF analysis showing oligol bands. As endocrinologists, we don't do it often, but sometimes it may be a big clue in cases of sarcoidosis. IGG4 related disease. So this is about IGG4 levels and the FDG PET looking for a biopsiable lesion elsewhere. Langerhans, especially in young adults and kids, you should go for a skeletal survey or a bone scan and look for bony lesion, because it is one of the favorite sites. Germinoma, I have already mentioned. LDH is something which you can do, and high LDH may give you a diagnosis of a lymphoproliferative disorder. CSF analysis may be important in selected cases. So it's not to say that all patients to undergo all these things. It's basically about clinical judgment. This just lists the investigations which helps us to come to a diagnosis of secondary hypophysitis. Serological markers. 10-15 years back, when we were students, there was this big thing about anti-pituitary antibodies. Now we know that these antibodies are not specific, and there are various antigenic agents in the pituitary which elicit these antibody responses. So we have this alpha enolase, GH, etc., etc. Doesn't make sense to remember all of these things. But the important thing to remember is that these antibodies are positive in patients with pituitary adenomas, tumors like germinomas, in a small percentage normal patients as well. So it's not very specific. So the best technique is an indirect immunofluorescence in pituitary, human pituitary sections. Some of the antibodies which have been described of late and are supposed to be more specific are these anti-hypothalamic antibodies, anti-ADH antibodies, and this anti-rapfillin antibodies. This is supposed to be seen in a large number of patients with lymphocytic infundibulohypophysitis. So just we have been talking about a lot of theory now. Let's discuss some case scenarios now. This is a girl whom we saw around 2 years back. She was a student who had come with headache, vomiting, left knee joint pain and swelling, missed periods, weakness. The investigation showed high inflammatory markers, central hypothyroidism, clear cortisol insufficiency. Then so we imaged the pituitary to find this classical appearance of hypophysitis. Examining her, we fortunately picked up this. This was this lacrimal gland enlargement. So at this point of time, we had the working diagnosis of she did not have any dryness of eyes. So our diagnosis were those disorders with lacrimal gland enlargement. So we put sarcoidosis and Sjogren's as first, followed by IGG4 disease. So instead of wasting a lot of time, we went around a biopsy and also did a bit of imaging, PET imaging elsewhere. So we found this lymph nodes in the mediastinum, and we hit gold with this lacrimal gland biopsy with a granulomatous lesion, Langerhans giant cell. And so this was a case of sarcoidosis, and she's doing very well, and steroid and mycophenolate morphine. So about sarcoidosis, so this is something which is well known to all of us. There may be some amount of pleocytosis and high protein in the CSF, and there are many series in which they are prominently mentioned the soluble interleukin-2 receptor levels, which is kind of indicative of a lymphocyte activation, found to have modest sensitivity and specificity. I don't think Indians are big fans of this, but this is probably interesting to know this. The important thing to notice is up to 2/3 of patients with this hypophysitis due to sarcoidosis have normal ACE levels. So if you are thinking that you do an ACE levels and sarcoidosis is ruled out, that may not be the case. So that's a very important take-home message. This is another case, a 46-year-old lady who presented to us with polyuria. She was, when she was referred to us, she was already diagnosed with central diabetes insipidus. The additional clues were the presence of epistaxis and vague joint pains. The imaging was already done outside. It kind of, the pituitary looked normal to us. So no stalk thickening. I think most of us would agree with that. The pituitary did not look very impressive. There is no classical hypophysitis-like appearance. So just to stress the fact that not all hypophysitis will have this classical appearance. The inflammatory markers were clearly high, and this is something which had been missed outside. And you know, the importance of all these good old investigations. The urine routine picked up numerous RBCs. So we put the ESR, RBCs, and the epistaxis together. So we were looking for a sort of something inflammatory. So we had an autoimmune disorder in mind. Topping our list was vasculitis, followed by another thing like SLE. So this is what we did. So the we don't have the dsDNA. The dsDNA and the autoimmune markers were negative, but we are a strongly positive ANCA. We tried for a biopsy in this patient from the nasal cavity. It did come out with inflammatory lesions, but no granulomas were the same. But our rheumatologist was very convinced about a diagnosis of a limited granulomatous polyangiitis. So in the literature, if you look, there are several reports of this advanced granulomatous polyangiitis is known to be associated with hypophysitis only if it is very advanced. But of late, there are several reports of this limited involvement, and we should not let the normal MRI or so-called normal MRI fool us. This is, I've just taken photo from the illustration from the net. We had this case, I had seen this sort of case during my training days. We had made the diagnosis, unfortunately, with one of those ominous computer crashes. I had lost this, all the good photographs. So this is what, you can see this eye appearance. So this sort of xanthoma-like things in the eyes, involvement of the aorta, involvement of the bones, masses elsewhere. This is Erdemchester disease. So, one of the big clues is this presence of this granulomatous, xanthoma-like lesions around the orbit. So, and Langerhans histiocytosis. Also, we have cases where patients may present with diabetes insipidus, both adults as well as children. And the pituitary MRI, even on careful scrutiny, looks absolutely normal. Frequently, there are other sites of involvement, and biopsy leads to the diagnosis. IGG4 hypophysitis, an entity which has been described probably in the past 10 to 15 years. It has come up in a big way. And in a recent publication from Japan, 30% of hypophysitis turned out to be IgG4 disease. Many of them were earlier mistaken as a lymphocytic hypophysitis. So, myriad of radiological findings. Please note this central necrotic area can even present like an empty cella. So, one of the characteristic histopathological features is this cartwheel storiform fibrosis, and there can be involvement of or other organs. This is a big list. I'm sure all of you are aware of the other sites of IgG4 hypophysitis involvement, and the tissues stain strongly for IgG4 positive plasma cells. So fortunately, there is a diagnostic criteria just been developed as a result of international efforts. So criterion 1 is the most important one: mononuclear infiltration with IgG4 positive cells, more than 10 per hyperfield. There are other features like involvement in the pituitary and stalk, IgG4 lesions in other organs, and IgG4 levels. So anything more than 140 milligram per deciliter is considered to be very significant and suggestive. But it should be noted that up to quarter of patients with IgG4 disease do not have increase in serum immunoglobulin levels. So we have to rely on biopsy in most of the cases. The response to glucocorticoids is striking. So I remember this patient who had been operated outside, and probably they put a diagnosis of lymphocytic hypothesis. She had this blindness and orbital involvement. And there was this mention of fibrosis. We couldn't do the IgG4 cells because the surgery was done outside. If we came across fixed specimens, but then we started on just 30 milligram steroids. So we talked to her in the evening, started the steroids. Next day evening, she started, her vision was back to almost 6/9. So it's just 24. So the response was like very dramatic. You don't see that kind of response in lymphocytic hypophysitis. It takes few days. So diagnosis established when you have criterion 1, 2, and 3, or 2, 4, and 5. Another case, 64-year-old lady with fever and lethargy, altered sensorium, hyponatremia. She was proven to have hypopituitarism, and the imaging showed features of hypophysitis. MTCT chest and abdomen was normal. This was more than 10 years back. We did not have the PET CT then. So the MDCT was normal. So pituitary biopsy came up with a very surprising diagnosis. This was non-Hodgkin's lymphoma, intravascular B-cell lymphoma. And then she was referred to our regional cancer center, and she expired within a span of 2 months. So what are the indications for biopsy? So there are no clear-cut guidelines for adults, but these are some of the situations. The diagnosis is unclear after investigations, and there is a significant suspicion for a systemic disease. There is clinical deterioration, hormonal, visual, and structural. So obviously, sometimes biopsy is coupled with a decompression. Pathology results, sometimes we think that it will facilitate long-term treatment. So for example, if you have an IGG4 disease suspicion, so if you do a biopsy and prove it, you know that that patient, it's very difficult for us to take the patient off steroids long-term because there is a high incidence of recurrence. Stalk thickening more than 6.5 millimeter in pediatrics. That has been mentioned as one of the criteria where you should go for a biopsy. One of the reasons is there is a high incidence of these germinomas and other tumor-like situations, and we don't want to miss that. Progression and management. So we should understand that there is a dearth of quality information because there are no RCTs. It's very difficult to have RCTs for this rare conditions. So the validity of and the biopsies, of course, it has not been done for all patients in all large series. Generally, the three approaches are, in my cases, it's about observation and replacement of the hormones, immunosuppression for moderate cases, and surgical interventions for that severe cases with compressive features. If you look at this German series, you find that the regression in the observation group is close to 50%, and the improvement of pituitary function is seen in at least a quarter of patients. The steroid treatment group, there was an initial regression of the MRI in 66%, but overall the response it recurred in 38% of patients. The improvement was a dismal 15% of patients in this series. But if you look at the KEM series, so this is an important table from the KEM series. So you have the pituitary axis recovery here, complete, partial, and no recovery. You have the three groups, the TSS surgical group, watchful monitoring, and steroid pulse therapy. The biggest group is a watchful monitoring or observation group. You can see that this is around 33%. This is percentage. 33% of patients had recovery of the pituitary axis. This is a very small subgroup, patients with steroid pulse therapy. So here, this is a very dramatic thing which has not been replicated in other publications. The recovery of pituitary axis is almost 100%, complete in 75% and 25% partial. So, but this was just for patients. So I leave it to you to make your own conclusions about this. But it's definitely useful in some patients. But we don't know whether it's spontaneous recovery. When steroids don't work, there are these second-line agents to resort to, and these include azathioprine, MMF, methotrexate, cyclosporine, and azathioprine has been the favorite in most studies, and even radiotherapy and rituximab has been tried. Rituximab is coming up in a big way, and for both lymphocytic hypophysitis resistant cases as well as even the other cases, IGG4 disease. So this is one study looking at factors predicting responsiveness to glucocorticoid therapy. So anti-pituitary antibody presence in the study, occurrence of diabetes insipidus, absence of the bright spot, and pituitary stalk at optimal chiasm larger than 3.9 mm. But this is just one study. Just wanted to put it up because this is just one. This is the only study of this sort available. And this was a prospective double-arm study. So we looked at all the entities now, and we saw that the treatment outcomes varies and in lymphocytic hypophysitis, we observe or use glucocorticoids and or immunosuppressants. And the others, most of the time, we have to intervene, decompression, and they are less responsive to immunosuppressant therapy. Let's come on to the newer forms of hypophysitis. There are the three forms the main forms include PIT1 antibody syndrome, immune checkpoint inhibitors, and isolated ACTH deficiency. And anti-PIT1 transcription factor related hypophysitis has been described only in the past 10 years and only in a handful of patients. So what people found is that they had this peculiar distribution of hormonal defects, and that is what made people think about PIT1. Growth hormone, TSH, and prolactin were knocked off. Mostly seen in elderly individuals. Pituitary MRI is normal or atrophic, and most of the patients had this PIT1 antibody on immunofluorescence. There was a temporal relationship to thymoma in many of these patients, and there were patients with non-thymoma malignancies as well. For example, this unknown metastasis and bladder lymphoma as well. So this kind of sometimes can predate the tumor also. So if we have this kind of combination, we have to start thinking about anti-PIT hypophysitis, even if the pituitary MRI is seemingly normal, and start searching for tumors. Mechanism is an ectopic expression of PIT1 in the tumor, results in immune dysregulation and loss of immune tolerance, and the cells start attacking the PIT1 expressing cells in the pituitary. Similar mechanism here, isolated ACTH deficiency. Any endocrinologist who has been around for more than 10 years or so would have encountered these cases of isolated ACTH deficiency. All the hormones are normal. Sometimes the pituitary MRI is also normal. So now there is a small twist to this thing. People have found that sometimes, not in all cases, this may be a paraneoplastic manifestation. So same mechanism here, large cell neuroendocrine tumor, ectopic expression of POMC, and then the poor POMC in the pituitary is put to attack by the cells, and you have this ACTH deficiency. The immune checkpoint hypophysitis. So we have anti-CTLA4 drugs and anti-PD1 and PDI-L1 this thing drugs. So the mechanism is supposed to be both a humoral insult as well as cytotoxicity. It's more common with anti-CTLA4 therapy. So in the PD1, that's a programmed cell death protein and programmed death ligand 1 associated hypophysitis. It's a mild disease, not much of local effects, not much of MRI changes or headaches. Frequently, it's just adrenal insufficiency and usually occurs later during the course of therapy. This is unlike the CTLA, where it's more severe. There may be some MRI changes, and the other hormones may be also be knocked off. So I think if you have this sort of a presentation, it might do well, to do a good Google search of all the maps and see if it fits into one of those maps which you talked about. Autoimmune hypothalamitis, hypothalamic mass defects, most commonly central diabetes insipidus. People have even come up with a criteria, which I encourage all of you to read. So it's a very rare situation, but the important thing to note that it's just an inflammatory mass and it's likely to respond to immunosuppressants. So important to do a biopsy to prove this. So the only clear guidelines is from the Japanese Endocrine Society, probably because they have a high prevalence of all these autoimmune hypophysitis disorders. So in mild cases, no compressive symptoms, wait and watch. Moderate, systemic steroids, oral. you use it for 2 to 3 months and taper. May not be able to stop in all cases, especially with IG4 related hypophysitis. And in severe cases, it's about pulse therapy with middle prednisolone, different schedules. They have gone for doses ranging from 80 to 120. These are the recommendations, and I encourage all the postgraduates to read this endocrine journal. So we come to the summary slide now. So it's about, we talked about clinically suspecting hypophysitis, followed by imaging. So the next thing is about figuring out whether it is secondary forms of hypophysitis or is it a lymphocytic hypophysitis. We talked about all the investigations. If it is mild, it's just observation. If it is more than mild, then it's about glucocorticoid therapy, and there are other immunosuppressants as well. And if you find a secondary cause, the treatment has to be individualized. And IGG4 disease is something which is very highly responsive to steroid therapy. And we might have to go upon the immunosuppressive therapy as time goes to keep things under control. And even radiotherapy has been tried out in cases of hypophysitis. So I would thank all of you for the patient hearing, and I hope this session was useful to all the postgraduates. Thank you very much.
Thank you, Dr. Praveen. That was an exhaustive and in-depth discussion on a very difficult topic. And the cases which you showed. Hello. Am I audible?
Yes, ma'am. You are audible.
Okay. Okay. And your case series was also very rare, and it was a beautiful presentation overall. What I'd like to know is, this classification as we have right now, I think there is need for reclassification, because the primary and the secondary, all those classifications we get to see, there is definitely an overlap, because IGG4, we usually see it in the primary group, but then there is involvement of other organs also. So this sort of thing, I think as the years evolve, it will become more streamlined with improvement in our technology. And another thing I think which is a bit controversial is the the response to glucocorticoids, because that is what we have in our hands at the end of the day, and with different series reporting different responses. Like the KN series was, our Indian was totally different. In others, the relapse rate is much higher. So I think that is another area we need to know more about. And from the clinical point of view, with this increase in the immune checkpoint inhibitor therapy, with the increase in the more and more people being put on this therapy, I think we have to become more cautious. If an elderly male, he's complaining of headache maybe after 2 or 3 cycles, because nausea, vomiting, other signs are so common in a patient with carcinoma that those will always be missed. And moreover, here the DI or visual disturbance, etc., are very rare. So I think we have to have a high index of suspicion and approach it. Once again, thank you for your beautiful presentation. And now I think we can have some questions from our DM students or our faculties.
Yeah, thank you, ma'am. Well said. I think we have summarized what has to be mentioned about this thing, about all the confusions and this thing. So I think the Japanese society thing is a very practical thing.
Yes.
They put it in this thing. Don't jump in and do a lot of things. Smile, you just wait, and all those stuff. So this question talks about pediatric age group, MRI, and shows incidental hypophysitis. My first comment is in pediatric age group, especially girls, you have this pituitary, which is kind of triangular, and if you look at the size, it might look a bit larger than normal, and it mimics hypophysitis in many aspects, except for the stock involvement. So making the diagnosis without clear things to support you would be a bit going overboard in pediatric age group. So suppose you come across these sort of patients. I think the thing to be said, I encourage the person who has put the question to read this very good publication in Lancet Child and Adolescent Health. It came up this year only, and it was a very practical discussion about this aspect done by the experts from NHS. So it's not like the US group where you go out with all guns flashing. Very practical thing. So basically, they have said that the one of the things, the two key messages which I got was, don't jump in and make a diagnosis just because it's a bit larger gland than usual. You have to look at all the things. For example, significant stock, yes. And the other thing is that don't miss tumors. So the tumors, especially germinomas, the germ cell tumors. Second would be an LCH. So if you have a suspicion of, clear suspicion for this, you should look for the secondary causes in a subtle manner, depending on the patient's thing, and then keep the patient on follow. But if you have any suspicion about germinoma, so that would involve a bit of stalk thickening as well. So then you should go and biopsy the patient, because the tumor markers many times may not give the full picture. Even in CSF, especially the CSF, many of the assays are not designed to look at the CSF, AFP, and all those effects, matrix effects, and all those stuff. So it's kind of a clinical thing actually, and requires a bit of follow-up also.
And in children, particularly, they may present solely with diabetes insipidus. So when we are working up those patients, we must keep histiocytosis at the back of our minds. And unlike in adults, growth hormone involvement is also more commonly seen in children. So these are perhaps a few areas. And then, of course, the issue of germinomas and histiocytosis is.
I might add, ma'am, that there is some follow-up protocol also mentioned. So you are supposed to follow up these patients with periodic MRIs every 6 months for at least 3 years. And even after that, these patients should be kept for a follow-up for the hormonal profile. So you should not let go of these patients and keep the antennas up for something coming up. Even if the first MRI is normal, as madam clearly mentioned, the child coming with central DI, the first MRI may be completely be normal. You keep on doing it every 6 months, and then the third or the fourth MRI may sometimes suddenly show up this slight stalk thickening coming up.
Any other questions? I don't see any other questions in the chat box. Do you have any questions in your chat box, Dr. Praveen?
No, ma'am. How aggressive should we be? I think we have already answered that question. Yeah.
Yes.
So,
Moutusi, may I ask Praveen, how often in series you have seen that lymphocytic hypophysitis or other forms of hypophysitis being presenting as an incidental?
yeah, so I think the incidentaloma series, there are no big incidentaloma series. Most of the time, there was some clinical thing. So either it was a local thing, visual deficits or something, or a hormonal thing which led on to the diagnosis. But of course, there are other situations. For example, your this IGG4 disease, or your Langerhans, all those conditions, there are this incidental stuff. So the primary hypophysitis, incidental, I didn't come across many reports, I must say. But the secondary, yes.
Thank you.
Welcome.
There are no more questions in the chat box. Thank you, Praveen sir, for the extensive talk on the rare disease. Thank you, Motosi ma'am, for giving your valuable time for this session. And the reminder for the next 4E webinar that will be held on the 19th November. The topic for the 4E webinar is the side effects and the complications of the insulin therapy. And the speaker is Dr. Ajay Hanumantu, and the chairperson will be Mukut Roy, sir. Thank you, everyone, and good night. We will conclude this session here.
Yeah, thanks.
Thank you
It's
very
been a
much.
pleasure. Yes, for
Thank
that
you.
excellent talk, and it was a very good session. Thanks.
Thank you, Mang. Thank you, everyone.
Thank you. Good night.
Thank you, Dr. Nilanjan. Thank you.